Welcome. My name is Edward Vieta. I'm professor of psychiatry at the University of Barcelona, and I'm also co-chair of this educational activity called ACUMEN, which is endorsed by the World Federation of Societies of Biological Psychiatry. Today we're going to cover a very important topic, which is the long-term outcome of cognitive impairment in the context of bipolar disorder. We're going to cover issues such as the longitudinal course and outcome of the cognitive deficits that we often see in patients with bipolar disorder. We're going to discuss how to incorporate strategies for the prevention of cognitive impairment and overall management of patients with bipolar disorder. And we also will speak about the development of routine assessment and long-term monitoring in these patients. And we want to track particularly also the cognitive impairment that we see in some of those. And with this aim, it is my pleasure to have with us, my good friend, Professor Guy Goodwin. He's an emeritus professor at the University of Oxford in the UK. And, he's been doing such a great job in this area that we're going to cover today. So, Guy, welcome.
Thank you.
So let's start covering this issue that is quite, I would say, neglected in general in clinical practice, which is the long-term outcome of cognitive deficits or cognitive impairment in bipolar. What is the trajectory of cognitive impairment in bipolar disorder?
Well, I think what I'd like to do is just to start with maybe going back 20 years to where this neglect really comes from. I would have said that in those days, 20 years ago, we had a somewhat false image of bipolar disorder. We thought of it as a relapsing, remitting illness, with the emphasis on the remission. And the contrast was made with schizophrenia because there was less remission in schizophrenia. And I think when I was educated as a psychiatrist first, that was the way we saw it. Now, I think the realization took quite a long time that in fact the poor functional outcomes we saw was something that we had to explain, that they weren't simply explained by continuing symptoms. There must be some other factor. And I think it was about that stage that probably both of us got interested in how we might get a handle on that. And we both took seriously the proposition that you could measure this. And measurement meant going to conventional neuropsychology. Now, those measures were really developed to detect lesions. And we weren't trying to detect lesions, we were trying to detect impairments. And so we started by measuring things that we call measures of memory, measures of attention, memories of executive function. And we started to do that, and as you've heard in other parts of this series, there's detail on what those deficits are. So we started with that observation, and clearly in our minds at that stage, there was the question of how do we get to these bad outcomes? Is it to do with the illness itself? Is it to do with cognition? How are the two related? And how is it related to function? So that's our starting point on this little journey, as I remember it.
Yeah, I remember it very well because both your group and our group were amongst the first to study this important issue that, as you said, it was not fully covered in the past. But when does it start? When does it change with successive episodes or duration with the bipolar disorder?
Well, I would love to be able to say that we have a clear and absolutely crystal clear understanding of causation. We have a pretty good understanding of correlation. We know kind of when things happen, more or less. But we lack an absolutely definitive prospective study of the trajectories of bipolar disorder. So what we have to fall back on are existing cohorts, which sometimes are a little prejudiced by sampling, which are sometimes difficult to maintain over time and are often too small. So those are the caveats. We don't have a perfect story. But what we seem to see is that if you take patients after a first episode of mania and you ask the question, are these patients already impaired? The answer seems to be yes, they are. There's nothing very specific about this. It may affect all domains of function, and it tends to be not as severe as you see in schizophrenia. So that's kind of the starting point. Yes, it's present from early on. Now, there have been some follow-up studies. You've done them, others have done them. They've been as good as they can be given how one has to recruit the patients and what we know about them. And what they suggest is that there is a tendency for some patients to get worse over time. And as they get worse over time, their illness in other ways is often getting worse over time. So we kind of have this image of progression of the disorder, which we sometimes call neuroprogression. We've got some imaging evidence that that's accompanied, for example, by white matter abnormalities which get worse. But we have some uncertainty as when exactly it starts. You know, are these people actually impaired before they get the illness, because we can't really recruit before the illness starts in a very reliable way? Are the people that we do study prospectively fully representative? Those are questions that I think, in my mind, are still not answered. But what we do know is that if you look at at-risk groups, they certainly show abnormalities of white matter connectivity, and that may be a vulnerability factor, it may not be an impairment factor. And we seem to know that when they get ill, they already show early impairments, and those impairments tend to get worse over the long term. That's the average picture that you see in the cohorts that have been studied so far.
But there is some controversy in the field about the neuroprogression. Could we say that we can reliably define subgroups, patients who do neuroprogress, others who don't?
Well, I still think this is really one of the most interesting questions, and it's tantalizing because the groups are not, they're defined statistically. They're not really defined on the basis of a clear-cut diagnostic criteria. But what basically you see if you take mid-career patients who've been ill for a long time, and you look at the profiles of cognitive function, it's pretty clear that there are some people who are doing just fine and their cognition is preserved. And there are other people who are really doing terribly and their cognition is terrible. And interestingly, I think, and maybe we'll talk more about this because this is one of your areas of expertise, those impairments seem to correlate with functional outcomes and the measures of functional outcome that you've pioneered the determination of. And of course, ultimately, clinically, that's what matters. The cognition is only really important to clinicians as a proxy measure of the risk of functional impairment. So I think we can say that there is certainly one group who look as if they've done very badly, almost as badly as patients with schizophrenia. There's one group who seem to have done fine. And then, depending on what sample you look at, there's maybe a third group with a kind of patchy impairment, maybe more impairment of memory than other things. So there's maybe three groups, but you have to say that they're statistically fuzzy groups. They're not kind of clear-cut groups. And of course, if you're talking about causality now, we have to remember that the challenge for the future will be to map all of our phenotypic descriptions onto the genetic architecture that is slowly but surely coming along from the large-scale GWAS studies, and also from looking at the less common mutations which seem to contribute to particular risks in neurodevelopmental pathways. So my feeling is that the phenotype tells us there's something very interesting going on. We know that by midlife the patients are grouped rather differently statistically. We don't quite know in terms of neuroprogression whether this is something that we can start to explain with genes.
And are there maybe any clinical features that could help clinicians to identify who's more likely to develop this cognitive impairment or these trajectories?
Well, I think, unfortunately, it's a correlation rather than a prediction. But patients who are having frequent recurrences, who are having bad illness courses, who are having recurrent depressive and particularly manic episodes may be the ones who are most at risk of showing the worst of these conditions. I think the caveat to that is that if you think about this, it's very tempting to think, and it helps us to think in this way, if people have a poor outcome, they then get cognitively impaired, then if we can prevent the poor outcome, they won't get cognitively impaired. That's the kind of what we would like to think. But of course, there's certainly evidence from just recently from quite a large Swedish cohort that you can think about the trajectory of bipolar. This is not studying cognition, but it's studying illness course. That there may be a group, that there may be an overall tendency for patients to get sensitized, to show more frequent episodes, and that's true for maybe half of the bipolar population. There's maybe half who don't show that effect, but the other half have recurrences that get more and more frequent as time goes on. This is a very old observation, obviously goes back even to Kraepelin. But what you also find is that there's a final very high, the rapid cycling group, who now it seems may have particular sort of genetic profile, and the CACNA1A receptor has been implicated in this. Very exciting if true, which means that we might start to get to the point of prediction, which is genuinely prediction with something that clearly pre-exists the disease, which is the genotype. So my feeling at the moment is that we should be very alert for first episode patients who show early relapse and who show persisting symptoms. And it seems to me that as cognitive folklore goes, as clinical folklore goes, I think they're the group we should be most concerned about. But then they are the group we're most concerned about. So in a way.
This is very consistent with the current, healthcare policies as well, early intervention and so on, it has been described that this cognitive impairment can be primary or secondary. Can we do something about it? Can we do something about primary, or can we do something about prevention of secondary cognitive impairment?
Yeah, I mean, obviously, we've really been talking about this concept of a primary impairment, a neuroprogression that's related to bipolar disorder per se. These patients may be at risk of cognitive impairment, which is secondary to poor medical conditions which are serious in these patients. And we know that as a group, the patients are more at risk of metabolic syndrome, they're more at risk of hypertension, they're more at risk of cardiovascular disease, stroke. So that these secondary causes, once the patients age into middle and later life, increasingly assume importance as secondary causes of which are disease-related. And the other secondary cause that and it's not really secondary, but it's sometimes easy to overlook, is of course depression itself. And the whole issue about bipolar disorder is that patients have recurrent manic illnesses which attract our attention because they need admission, but they often are left with chronic depressive symptoms that it is too easy to leave untreated, but also difficult to treat. So, that's the other cause that we have to think about in terms of our clinical management.
Yeah, indeed, bipolar depression and its chronicity is one of the greatest challenges, isn't it?
Yeah.
And what advice would you give to patients and families about this primary cognitive impairment in bipolar, this potential neuroprogression of the illness?
Well, we both believe in psychoeducation, right? So what we want to do is to explain to people the need to remain well, the need to take risks. Kay Jamieson says, look after your brain. And we kind of have to say that to patients and say that one of the risks is that they won't have the sort of cognitive flexibility and speed that they had when they were younger if they're not careful. I think that's a pretty useful health message, actually. Alongside that comes the problem that for many of our patients, the illness interrupts their career, their life, their achievement in a way that is deeply disappointing. And frankly, there is a point at which they have to make adjustments to the new reality of their life with bipolar patients if they're in the unfortunate group who are doing badly. And I think then our responsibility is to kind of help to manage expectations. We put that in guidelines in the UK. I don't know that there's evidence that it's particularly helpful, but I tend to follow that principle because people may, after a recovery from a whole sequence of illnesses, of having lost a great deal of ground in terms of their education, they may still expect everything's going to go okay. And I think one just has to be realistic that it's very unlikely that it will. And whether one can get people to kind of change course when you make that advice, I don't know. I can give you a very interesting example of this, of a man that I knew many years ago in Edinburgh. And he was a patient who had a single manic episode, very well documented back in, I think it was in about the 1940s. And I was seeing him again after he'd retired, and he had a second manic episode. And what was fascinating was to look back and to hear his account of the advice he was given. And in a way, it's very much something we would now frown on, because he was told that this illness meant that he must have a stress-free life, he must not be ambitious, he must do nothing.
Really?
Yeah. And he'd taken that advice, and he'd taken a very low-powered job in the civil service, and he had remained well. So you kind of think you have to be a little bit cautious about the advice you give. You don't want to blight people's ambitions, but at the same time, you kind of got to be realistic after a certain time about what's going to be possible, and to help people to accept that, it's not a failure not to become, the #1 engineer in the class, etc., if that's not going to happen.
But it's so hard for young patients to, accept that they have to take medication for a long time, etc. It's sometimes difficult for them. Denial is a temptation, isn't it? To some extent.
Denial, of course, for many of us as we grow older, is an option that we tend to exercise more and more frequently.
Right. So, should patients with bipolar disorder be regarded as a risk group for cardiovascular disease. You mentioned this as the secondary causes already. There's anything we could do about this, to lower this risk? Or?
Yeah, I mean, for sure. I think one of the sadnesses is to see that our patients tend to have a low priority in terms of their physical health care. They don't get the treatment they need. And if you look at the survival figures, they're really alarming, that people lose, maybe 10 to 15 years of their life to usually physical disease. Of course, suicide is the other major killer. But it's surprising, and it's early, this death from cardiovascular disease. So I think there's a pretty good case for saying that, if you have even borderline abnormal risk factors, lipids, blood pressure, that you should be treating that, because we know these people do really badly in the long term. And the drugs that we have to treat it were shown to be effective, and they are pretty innocuous to take. So although one is adding to the drug burden, I don't think, frankly, that this is a group where diet and exercise is always going to cut through. So I think you've got to have a pretty low threshold for trying to treat them for the risk factors that they show. Even when you do that, of course, you face the fact that they may have a worse prognosis for other reasons because of the way in which their lifestyle pans out, and whether they smoke, whether they are overweight, whether the drugs make it difficult for them to be underweight. That kind of thing, of course, is an issue that you have to think about as well.
Yeah, this points to the importance of monitoring health in general, not just mental health. But what do you think about self-monitoring by patients?
Well, I'm a big believer in that. I mean, if we look at the whole movement around cognitive behavior therapy, probably the single activity that all CBT protocols have in common is self-monitoring and looking at activities, scheduling activities. It's very simple stuff, but it essentially makes people reflect on what they're doing, and it helps them to think about their illness course and the trajectory, what's happening to them. So I think the principle is absolutely established across psychiatry. In the particular case of bipolar disorder, our experience of this goes back quite a long time now. It goes back to the mid-2000s. And we were sort of early adopters of very simple text-based technology to get patients to report their symptoms.
That was SMS, right?
Yeah, no, it was SMS. And we proudly used the lowest common denominator of technology, which was old Nokia phones. You could do it on an old Nokia phone, you could do it on anything. So we had a computer system which had a gateway to the telephone network, and we could send out texts and we could receive texts, and these could be analysed and put into a spreadsheet, and we could basically get weekly scores of patients' state. And we could do a standard depression scale, standard mania scale, although that's a little less valid, but nevertheless you do it, or you could do anxiety. And of course now we're in a position where I'm afraid Nokia and Nokia phones are something we've forgotten about. And it's very much easier, either on mobile platforms or indeed on desktops, to provide patients with a platform for self-monitoring which can be increasingly sophisticated. And I think the future is there. We did a pilot study looking at, admittedly somewhat selected patient group, but in that group the compliance was very, very high. And we've repeated that experience across Europe in general practice with patients with simple depression. And it's pretty, I think it holds across the whole group of mood disorders that it's a helpful thing to do, and that patients like it. And when they get a text or an email encouraging them to fill out a form, you might think that that would be a bit of a chore, that they wouldn't really enjoy doing it, but actually it's sort of an involvement in care which they often appreciate, and they see as providing a link directly to the service that's looking after them. And the compliance, therefore, is pretty good. And we would find, I suppose, in the experimental group who've been highly chosen, maybe 80% compliance, and in the clinic population, something like 60% compliance with this kind of methodology.
But as you said, this is not everyone, right? What can you do with the patients who do not like or want this self-monitoring?
Yeah, I think that's they're a very interesting group. And when you talk about this methodology, people will always say, well, what about, these people are not going to use it, and these people are, they're in some sense being excluded, which of course is, we all know, a very bad thing. I think the lesson around this is that if you look at the numbers who use this technology, it pretty much is the same number as actually take medications regularly. And so when you're non-compliant with this kind of technology, you're probably going to be non-compliant with other kinds of things. So the issue for your psychoeducational target is really to say, well, you know, compliance in general in this group is probably pretty poor. So we shouldn't give it as a sort of, oh, well, this is an absolute, this is something that we can't do anything about. It should help us in our mission to try and improve adherence to medication and improve adherence to this sort of monitoring. So I kind of see it as a challenge rather than a barrier to the patients ever getting anything.
And what variables do you think are key in this monitoring for those patients who really accept that monitoring?
Well, at the moment, we kind of know that they will do a simple scale like the depression scale like the QIDS, and there's also a mood elevation scale called the ACUMEN. I think that probably, our routine is to do it on a weekly basis. You can adjust it and take it on a monthly basis, but you know, it works at a week, and most people say it's okay at that frequency. The challenge of the future is to see whether those sorts of feedback allow you to predict relapse. This is kind of the holy grail. And at the moment, I think we can't convince ourselves that we do that very well. And mania in particular is something where the first signal you usually get is that people stop filling in their forms. So, you know, you kind of, it's quite difficult. The interesting, very recent development that we've made is to try and look at individual symptoms and to use a very simple experiential scale, the sort of thing that people use in momentary sampling. And when you do that, you can do that at any frequency you like. It doesn't really matter too much. But what we found is that there is a difference between healthy controls and bipolars in the way in which these symptoms cluster together. And so I think there's a future when one might be collecting more sophisticated information. And of course there's another step that people speculate: movement, geolocation, things that give you frictionless measures of patient behavior, which will have the signature of the onset of mania or whatever. So, you know, that's kind of where people think it might go, but you can't hand on heart say that we're doing that now. Right. And there's voice recognition, there's expression recognition, you know. So I think the possibilities in this area are very impressive, and that's why I think we should be flagging it up in this kind of forum, even if at the moment we can't say, you know, use this particular approach. It's pretty experimental, but it's exciting.
And what about tracking cognition in that way?
Well, I think tracking cognition is part of this process, and I think we've already seen with the MindStrong approach. This is a company that Tom Insall was involved in for a short time. That what they were doing was taking speed of movement off the pad on a smartphone and trying to convert the way in which, literally the motor function of the individual, to see whether that could be used as a signature of cognition. I've seen preliminary data on that which looked okay, but whether it's sensitive to change, whether it's predictive, whether it really expresses something more than the sort of functional measures that we make or the more conventional neuropsychological measures, I think that's for the future. But clearly cognition is part of this sort of outcome that we're wanting to measure. I would have said that at the moment, if you wanted to do it simply and conventionally, in a way that maps onto existing neuropsychological literature, you'd probably go for something that is relatively easy to put on a platform and that captures some composite of attention, working memory, and speed. And the particular test that people have argued does that pretty well and is very, very widely used is the digit symbol substitution test. And that's something that is pretty easy to put onto a mobile platform and to get reliable results from. And I think that at the moment is possibly the simplest way in which you can get a measure which will be mappable onto a whole lot of other experience.
Yeah. And it's also very friendly because it's very short and...
Yeah. And we know that that's, I think one of the particular problems with the batteries that we all used to use is that fatigue becomes a bit of a factor as time goes on, as people do yet another test, and I think you clearly want not to have that as your major variable.
So thank you very much for this wonderful discussion we had. Could you summarize by 3 take-home messages for clinicians?
Yeah, I think so. I mean, the first one is to take this problem seriously and to have it in mind in a variety of ways in relating outcome to what happens to your individual patient. The second is to concentrate on trying to mitigate it, and that means treating the recurrence of the illness as best you can. Think about lithium, for example, as a major advantage for patients. And also to reflect that between episodes, depressive symptoms contribute to this cognitive difficulty. So strive, although it's not easy, strive to treat that depressive pattern that you see in your patients. And then finally, to improve monitoring, to improve our understanding of what's happening to the patient and their understanding of what's happening to themselves, so that the longer term we see better management by both sides of the therapeutic relationship.
Excellent. Thank you very much, Guy. I really appreciate your input on this important topic.
It's been a pleasure.